Hey guys, in this video we are going to study stomas, stoma formation, ileostomy, colostomy and the complications of stoma formations. So here we go. What the stomas? It may be colostomy or ileostomy. It may be temporary or permanent. Temporary or defunctioning stomas are usually fashioned as loop stomas, and ileostomy is pouted. A colostomy is a flush. Ileostomy effluent is usually liquid and colostomy effluent is usually solid. Ileostomy patients are more likely to develop fluid and electrolyte problems, and ileostomy is usually sited in the right iliac fossa. A temporary colostomy may be transverse and sited in the right upper quadrant. End colostomy is usually sited in the left iliac fossa. So here we got the two key points. Ileostomy कहाँ पर situated है? Right iliac fossa में, और end colostomy left iliac fossa में. All patients should be counseled by a stoma care nurse before operation. So now comes the stoma formation. A colostomy is a connection of the colon to the skin of the abdominal wall. An ileostomy involves exteriorization of the ileum on the abdominal wall. Most common indications of stoma formation are colorectal cancer, chronic ulcerative colitis, and Crohn's disease. So there are three C's of indications of stoma formation. First C is colorectal cancer, chronic ulcerative colitis, and Crohn's disease. Ileostomy revisions are most commonly performed for Crohn's disease. Appearance of fistula adjacent to stoma usually indicates recurrence of Crohn's disease. A special complication in portal hypertension is varices can form in the peristomal skin. Varices can form in the peristomal skin. What are the sites of stoma formation? Transverse colostomy in the right upper quadrant, ileostomy in the right iliac fossa, and sigmoid colostomy in the left iliac fossa, as we described earlier. So now comes ileostomy. Ileostomy in this opening constructed between the small intestine and the abdominal wall, usually by distal ileum. Indications of permanent ileostomy are for the patients who require removal of the entire colon and rectum, that is Crohn's disease or ulcerative colitis. Indications of loop ileostomy, cases where multiple and complex anastomosis must be performed distally, Crohn's or disease or CA rectum. Now come loop ileostomy. Use is becoming more frequent because of the complex sphincter preserving operations being performed for ulcerative colitis and familial adenomatous polyposis. What are the type of ileostomies? End ileostomy, loop ileostomy, and loop end ileostomy. Continent ileostomy and urinary conduit. Now comes continent ileostomy or cock pouch has been used as an alternative to conventional ileostomy for selected patients with ulcerative colitis or familial adenomatous polyposis. It is contraindicated in Crohn's disease, not recommended for well-functioning end ileostomy. It involves construction of an internal pouch with continent nipple valve. The complication rate for construction of this continent ileostomy has been high because of the difficulty in maintaining continence at the nipple valve and position of the pouch so that intubation can be easily accomplished. Continent ileostomy advantages are patient need not wear an appliance. Patient is continent between intubations, better quality of life. But what are the disadvantages of continent ileostomy? Not all patients are continent, require multiple intubations during the day, and this difficulty in intubation, prolonged surgery with substantial risk of complications are there. What is colostomy? Most common indication for fashioning a colostomy is CA rectum. Colostomies are also constructed as treatment for obstructing lesions of the distal large intestine and for actual or potential perforations. The type of anatomical location for colostomy are end sigmoid colostomy, end descending colostomy, transverse colostomy, and cecostomy. However, if IMA is transected, inferior mesenteric artery is transected during an operation for CA rectum, the blood supply in the sigmoid colon is no longer dependable and it should not be used for stomach construction. Therefore, an end descending colostomy is usually preferable to an end sigmoid colostomy. Now comes location of the colostomy should avoid any deep folds of fat, scars and bony prominences of the abdominal wall. The type by function is to provide decompression of the large intestine and to provide diversion of the feces. So now comes decompressing colostomy, the indications, and the diverting colostomy indications. The indications of decompressing colostomy are distal obstructive lesions causing massive dilatation of the proximal colon without ischemic necrosis. Second indication is severe sigmoid diverticulitis with phlegmon. Third is selected patients with toxic megacolon. Types of decompressing stomas are blowhole cecostomy, blowhole transverse colostomy, tube type of cecostomy, and loop transverse colostomy. What are the indications of diverting colostomy? First indication is when distal segment of bowel has been completely resected, as during APR. Known or suspected perforation or obstruction of the distal bowel, example obstructing carcinoma, diverticulitis, leaking anastomosis, trauma. Destruction or infection of the distal colon, rectum or anus, example Crohn's disease or failed anal sphincter reconstruction. Types of diverting stomas are loop transverse colostomy and loop sigmoid colostomy. Destruction or infection of the distal colon, rectum or anus, example in Crohn's disease or failed anal sphincter reconstruction. So now what are the types of diverting stomas? Loop transverse colostomy and loop sigmoid colostomy. Now comes the stomal complications. Now what are the complications of stoma? Most common complication of both end and loop colostomy is parastomal hernia. Parastomal hernia is more common in end colostomy as compared to loop colostomy. Prolapse is more common in loop colostomy. Most common complication of ileostomy is skin irritation. Most common early complication of ileostomy is ischemic necrosis. What are the stomal complications? Stomas are widely used in the treatment of colorectal, intestinal and urologic diseases. An intestinal stoma can be an ileostomy, colostomy or urostomy, end loop or end loop, temporary or permanent, diverting or decompressing, continent or incontinent. So these were the types of intestinal stoma, which can be ileostomy, colostomy or urostomy or end loop, temporary or permanent, or diverting or decompressing, or continent or incontinent. A tube cecostomy and a blowhole are considered temporary decompressing colostomies performed in emergencies. So in emergency, what do we perform? Tube cecostomy and blowhole are considered temporary decompressing colostomies performed in emergencies. The technical factors are most important in minimizing the complication rate of stoma construction and are largely preventable. Early complications are considered those that occur within 30 days after surgery. So clinical presentation and diagnosis. Ischemic necrosis occurs from impaired perfusion to the terminal portion of the bowel as a result of tight aperture, overzealous trimming of mesentery or mesenteric tension. So these are the stomal complications of which clinical presentation and the cause are explained here. Now comes first was the ischemic necrosis. Second is stomal retraction, occurs as a result of tension on the bowel or ischemic necrosis of the stroma. Third is late retraction, is caused by increased thickness of the abdominal wall with weight gain. Fourth is stenosis, as a result of small aperture, ischemia, recurrence of Crohn's disease or development of carcinoma. Mucocutaneous separation, as a result of ischemia, inadequate approximation of mucosa to the dermal layer of the skin, excessive bowel tension or peristomal infection. Sixth point is stomal prolapse. Stomal prolapse is most alarming to the patient and can result in incomplete diversion of stool. Interference with the stoma appliance lead to leakage of stool or become associated with obstructive symptoms and incarceration. Parastromal hernia, as we saw earlier, that it was the most common complication of both end and loop colostomy. Parastromal hernia occurs to some degree in most patients. Then comes peristromal fistula. It is a sign of Crohn's disease, may result from a deep suture used to mature the stoma, or may be caused by trauma from an appliance. That is peristromal fistula. How can it form? Then comes chemical dermatitis. It is caused by contact of the stroma effluent with peristromal skin. It is manifested as erythema, ulceration, encrustation, pseudoepitheliomatous hyperplasia. Then comes traumatic dermatitis. Occurs during change of the stromal devices from stripping of adhesive or as a result of friction or pressure from the stromal device or supportive belt. Manifested as erythema, erosion and ulceration. Then comes diarrhea and dehydration. Commonly occurs in older patients in hot weather during strenuous exercise and in association with short bowel syndrome. Then comes cutaneous manifestation of the disease. Damaged peristromal skin in psoriasis, pyoderma gangrenosum in IBD, and parastromal varices in portal hypertension. So these were the complications of which the clinical presentation and diagnosis was there. That is ischemic necrosis, stromal retraction, late retraction, stenosis, mucocutaneous separation, stromal prolapse, parastromal hernia, peristromal fistula, chemical dermatitis, traumatic dermatitis, diarrhea and dehydration, cutaneous manifestation of the disease. Now comes the stromal complications, mnemonic. So we can learn the mnemonic of stromal complications by dividing it into two parts: early complications and late complications. In the early complications, we divide it on three bases. That is at the level of stoma, and then at the level of peristromal skin, and in systemic complications what can occur. So in early stromal complications in stroma, the mnemonic is rapid O. So it stands for retraction, abscess formation, poor location, ischemic necrosis, detachment, and opening wrong out. In peristromal skin, what can happen? Excoriation can happen and dermatitis. In systemic, high cardiac output, high output can occur. And what are the late complications of stoma? At the level of stoma, the code is SPF GO. SPF is sun protecting factor, as we use in the sunscreen. So same here, we can learn it like SPF GO. Of stoma, S for stoma, S for sun, S for SPF GO, and S for stoma complications. So the enumeration of SPF GO is stenosis, parastromal hernia, fistula formation, prolapse, gas and udder. So at the level of peristromal skin, the later complication can be parastromal varices, dermatosis, cancer, skin manifestations of IBD. And at the level of systemic, two complications can occur: bowel obstruction and non-closure. So in this video, we discussed about stoma formation, ileostomy, colostomy, and the stromal complication. That's it. Thank you. And if this video was informative, please do like, subscribe and share it. And thank you for watching this video patiently and acquiring knowledge. That's it. Thank you.